The following program is in no way intended to replace your doctor's advice or treatment program, nor should it be used as a tool for the purpose of self-diagnosis.
Good evening. It's Wednesday, the 11th of December, 2019, our final program for the year on Your Health, Your Choice. For those of you who are regular viewers, quite a few sessions ago, we started a series called the Ominous Octet on Diabetes, and we want to end the year with completing that, perhaps this evening, with Dr. Claude Kahn, once more, community diabetologist.
Thank you.
And we have quite a series of slides to share with you and interesting information. And want to perhaps begin by you introducing the necessity for looking at the ominous octet as we go along.
Yeah. I just wanted to say, although we're saying it's a last program, it's a last live program.
Yes.
So you can ring in tonight later on in about maybe 30 minutes on 6524855. But the programs will still be replayed on Wednesday nights. And we're going to try and choose some different programs into the new year. So Wednesday nights, Thursdays at 1 o'clock, 1 p.m., and Sunday evenings at 6:30. Mm-hmm. It's the Advent season. Linda, you look very Christmassy.
Yeah, season for joy and gratitude and celebration.
Yes, dressed up in your red. I tried to get a red tie to match. Yeah. I think I did okay.
Yeah, you did pretty well.
Yeah, thank you.
So Merry Christmas, everybody.
Yeah, we'll end talking about the Advent season, but sometimes we are rushed. But I just want to say Advent is a glorious time of the year. It's a wonderful time. It's a time of celebration, family get-togethers, and Advent really means the coming of Christ. Mm-hmm. And we have been lighting the Advent candles in our church and the process, the candles of hope, peace last week. This Sunday will be joy. Mm-hmm. And next week Sunday, the last Sunday before Christmas, will be love. Yes. So that's really an exciting, symbolic way of celebrating Advent and the coming of Jesus Christ. But I guess we'll come back to that at the end.
One of the things we do a lot of at Christmas time in celebrating is overeating, right?
Well, overeating and not exercising, those are two things that seem to go through the window, and then people make New Year's resolutions and we kick off the new year again. We have just celebrated or remembered World Diabetes Day 2 or 3 weeks ago, and that was quite I want to congratulate the Diabetic Association of Trinidad and Tobago and the president of the Diabetic Association and all the good work that they have been doing. So we're coming back tonight to what we call the Ominous Octet, and I hope that we'll have time to cover it. But what we're trying to do is look at what we call the unmet needs in diabetes care. Mm-hmm. And we have slide 12, which really kind of summarizes some of the challenges we have in treating type 2 diabetes. So we see on the slide the multiple, so we'll be talking about the multiple defects in type 2 diabetes and the adverse effects of therapy, which a lot of patients are every day concerned about, asking me about what are the side effects of tablets, hyperglycemia, which is the very focus of diabetes.
Could you just define hyperglycemia?
High blood sugars. Yes. High blood sugars. But treating diabetes is not just about treating high blood sugars. In red, and I think that's an appropriate color, cardiovascular risk, CVD risk, looking at lipid control, cholesterol control, hypertension, all those risk factors, and then weight management, which is also another big unmet need.
That's quite a nice, colorful slide. I like the design.
Yes. So I think what we're trying to summarize there is the fact that treating diabetes is not just treating a blood sugar. It's trying to look at the underlying pathology, the underlying problems that we're dealing with, and focusing on that patient and trying to figure out, well, what is the basic pathophysiology that we are dealing with. Yeah. Well, pathophysiology talks about the underlying cause, what's happening inside the body at the biochemical level, let's call it that. So not all blood sugars should be treated in the same way. So, one patient may come in, they may be slim, high blood sugar. The way we treat that patient will be different to someone who's overweight. And then the way we treat someone who might be type 1 will be different to the way we treat a type 2 diabetic. The way we treat an 85-year-old will be different to the way we treat a 30-year-old.
Right.
So really, but that first slide was saying that there are unmet needs that we need to come to grips with.
Okay. So I know there's an interesting article here that Rafiq Shah shared with us. So I think it was the Diwali weekend.
Right.
And it was entitled "We Only Live Once," and I was quite taken with his understanding of how these lifestyle diseases develop. And the column began with, last week as I listened to Health Minister Terence Dial Singh complain for the umpteenth time about the high percentage of citizens who are literally eating and drinking themselves to chronic and costly lifestyle diseases and early deaths, I thought I needed to return to the topic I focused on my previous column, food production and consumption. And he went on to praise Minister Dial Singh and his predecessor, Fawad Khan, who led that Ministry of Health by example by themselves, trimming their weights and improving their fitness levels and so on, and went on to talk about the massive imports of the staples which actually create this eating our way to diabetes and to other lifestyle diseases. Yeah. He talked about our import bills for wheat, white flour, oil, sugar, rice, and he actually identified it as being responsible for the diabetes epidemic that has gripped the country. So I just wondered how you would respond to that. Well,
there is no doubt, absolutely no doubt, that our lifestyle has a lot to do with type 2 diabetes. So I just want to emphasize that again. There's type 1, type 2, and gestational diabetes. And certainly type 2 diabetes and to a certain effect, gestational diabetes, lifestyle is a foundational predisposing risk factor. However, I want to say where people misunderstand diabetes is where genetics is concerned. Because I will tell you, Linda, I have some lean, slim patients exercising, eating healthily, and they have diabetes. So
is that type 1 or type 2?
No, type 2 diabetics. And one of the things I find very often I have to explain to patients is that there's a basic misunderstanding, very much a simplifying. And with all respect to Rafiq Shah and the Minister of Health, I think we are missing the whole aspect of screening at-risk patients for type 2 diabetes. So there's what is called a Finnish risk score. Finnish risk score for diabetics. So when patients come through your door, if you're doing general practice or if you're in the health centers, you can do a risk analysis, not only on the basis of whether that patient is overweight or not exercising. Those are two of the questions, but what is the genetic history? Is there a history of hypertension? Is that patient a smoker? So what I'm saying is, and I don't want to make it overly difficult to understand, but I just want to emphasize you can take two people eating the same way, not exercising or exercising. One patient will put on weight, develop diabetes, the other wouldn't.
So you're saying there's no correlation between lifestyle diseases?
I'm not saying that, absolutely not. I'm saying that people need to eat healthily. Notice I did not say a diabetic diet. I did not say a ketogenic diet. People need to eat healthily. We need to cut down on our carbs, especially the refined sugars.
Which is what he identified as
absolutely,
the biggest import bills.
Absolutely.
Yeah.
But if we just leave it at that, we're going to miss families where father, mother is diabetic, and those people we really need to pinpoint we really need to focus on and get the message out tonight and in all our programs. If you have parents who are diabetic and you're in your 30s, 20s and 30s, start checking yourself, even if you are normal weight. I see young men, 6 feet 4 inches, slim, muscular, with diabetes. Okay, I'm passionate about that.
Okay, it sounds so.
Yes.
Okay, so you want to move on to slide 22?
So slide 22 kind of re-emphasizes this. The etiology, and I know you're going to ask me what I mean by etiology.
What do you mean by etiology?
Well, the causes. Etiology is just a big word for causes. And if you look at the left-hand slide, you see the primary predisposing factors. Now, this is important. Genes, genetics, and adverse intrauterine environments. Now, that's a big
what's an
term.
Intrauterine?
That means some babies in the womb have risk factors for diabetes.
Right.
And that was discovered years ago, that actually if you are born underweight, you have a higher risk of developing diabetes in older age. Right. And I don't want to get too much into that.
Let's go to the secondary ones.
Secondary factors, well, this is what we talk about: obesity, low physical activity. As you get older, there's a relationship between smoking and diabetes, sleep disturbance, obstructive sleep apnea. And there are other factors like polycystic ovaries, and then tertiary accelerating factors, glucose and lipid toxicity. So
well, we know toxicity has to do with poisoning.
Right. So very often, and even this week, I saw patients come in. One patient come in to me, referred from a company. I have some occupational health patients. They have gone in for routine medical checks, and they have found out their blood sugars are high. And you could see the surprise on these patients' faces, because they have absolutely no symptoms, no blurred vision, no excessive thirst, no problems passing urine, and there they go for a routine blood test, and their blood sugars are high. And what I have to say to them is that your blood sugar did not become high overnight. Your glucose started rising maybe 5 years ago. You became pre-diabetic, and then you become diabetic, and then glucotoxicity means high blood sugars suppressing the beta cells.
Right.
And that is compounded by high cholesterol. High cholesterol is lipotoxicity and free fatty acids, which suppress the beta cells and also allow the liver to do something called gluconeogenesis, which is producing glucose as well.
Yeah, okay. Right, so we've looked at some of the traditional causes. Do you want to move on to slide 24?
So we're now getting into some of the nitty-gritty factors which we talk about. Slide 24, which talks about the beta cell itself. So
right, so if you could explain about beta cells and alpha cells, that might help.
Well, okay, so I don't want to get into the alphas, because this slide talks about the beta cell. So the beta cell is in the pancreas, and you have insulin resistance. So I'll explain what insulin resistance is. And if you look at the right-hand side of the slide, Linda, you see what is called an abnormal beta cell.
Yeah.
And when you have insulin resistance, an abnormal beta cell begins to dysfunction. You begin to produce less insulin, and your blood sugars rise, and you develop diabetes. Now, if you have that same beta, well, not the same beta cell, but a normal beta cell with the same level of insulin resistance, you have compensatory hyperinsulinemia. Insulin levels increase, and your blood sugars remain normal. Now, I just want to come off this slide because I'm excited about this concept.
Yeah.
I get excited about little things in life, don't I? I tell my, when I'm doing talks, that I dream about the beta cell. I don't know if I actually do that. But the beta cell is in the pancreas, and the pancreas is situated just behind the stomach. Sometimes, we ask questions about pancreatitis, which is inflammation of the pancreas. But what is insulin resistance? So insulin resistance is where some patients, because sometimes obesity, excessive weight around the tummy, but sometimes genetics. So genetics will predispose a beta cell to be dysfunctioning at an earlier stage with the same level of insulin resistance. So you can have someone with the same body weight, same abdominal fat or lack of fat, and yet the body's producing insulin, and for some reason that beta cells begin to deteriorate. And on the other hand, you have another patient, same level of insulin resistance, beta cells are sensing that the blood sugars are trying to go up, and the beta cells begin to produce more insulin, and you have high insulin levels. Now, you don't develop diabetes, but you can develop what is called a metabolic syndrome. Sorry, I'm pointing at you. Never point at your wife, right? That's when I get excited, right? You don't develop diabetes, but you can develop what is called a metabolic syndrome. Yeah. Which is high blood pressure, high cholesterol, cardiovascular disease, etc. So I hope that was trying to explain what the and this.
I thought slide 25 would explain the stresses on the beta cell.
It does. So I know we'll have to go to a break soon, but if Josh can bring up slide 25 before we go to a break. So look at this poor beta cell. So the beta cell is in the pancreas. So why does a beta cell deteriorate? As you get older, the reality is your beta cells are under more stress and it's wearing out. There's genetics. If we go in a clockwise direction. So we
start with age, then we move
genetics. There is a genetic link called the TCF7L2 gene. No, I don't even, that's saying
we're not going there.
There's a genetic link. Then you have insulin resistance, which is due to abdominal fat, lack of exercise. You have lipotoxicity and free fatty acids, glucotoxicity, and the last one, amyloid. Amyloid deposition in the islet cells. So I know we have to go to a break, is that right? But can I just come off that slide? Some people are talking about another type of diabetes, which is amyloid related. And there's a relationship, some people think, between Alzheimer's disease, which is due to amyloid deposits in the brain, and type 2 diabetes, which is also due to amyloid deposits. Not that type 2 diabetics will get Alzheimer's, but there's some sort of link with amyloid deposition.
So the brain is an organ that can be affected by diabetes as well.
Absolutely, which we'll come to.
We'll come to it. So we're going to take our first break. When we come back, we continue with our integrating approach to healthcare on Your Health, Your Choice. Don't go away.
Looking for a safe place for the whole family? Well, now you've found it. We are ACTN The Voice, your family-friendly station. Whether it's current affairs, kids and classic TV, sport and community features, Christian and music programming, plus so much more, ACTN is the station for you. Join us each day for programming that puts morals, values and family first. We are ACTN The Voice, your family-friendly station.
Exclusively on ACTN The Voice. This is Messenger TV. Join us as John and Lisa Bevere equip and empower generations of Christians, both young and old, developing uncompromising followers of Christ who transform our world. Starting on Mondays at 8 a.m. with repeats to fit any schedule. Tune in, log in, or click on the Word like never before. Stay tuned for a new experience from the Word of God with Messenger TV, exclusively on ACTN The Voice.
You're watching ACTN, The Voice. ACTN The Voice, your family-friendly station. ACTN, the voice of Christmas.
Welcome back to our Christmas edition of Your Health, Your Choice. And before the break, we were looking at two of the major causes of type 2 diabetes with Dr. Claude Kahn. We want to move on now to the third, which we call the triumvirate.
Is that right? You can pronounce it better than me.
3 traditional triumvirates.
Right. So we are looking now at a third. We talked about the beta cell not producing enough insulin. We talked about insulin resistance, which is where the body is not utilizing your sugar. So I always say to people, sugar is not bad. And I know people will want to debate that with me. It obviously depends on the type of sugar you're taking in. You don't want to take in too much of the simple sugars or refined sugars. The problem with diabetes is that the sugar stays in the blood. You become too sweet rather than going into your cells. That's why if you give people too much insulin or too much medication and their blood sugars drop low, they can have a hypoglycemic event. So the whole aim of diabetes is to help people to mobilize the sugar out of the blood into the cells. So we're going to show slide 29. And this is where we are getting now further into the pathogenesis of type 2 diabetes, slide 29. So
it's called the triumvirate because we're looking at 3 areas.
So we have already talked about, if we go in a clockwise direction, the beta cell. That's impaired insulin secretion.
Right.
Then you have insulin resistance, where the body is not able to take up the sugar despite you having insulin. Your body is not responding to the insulin. And now we have the liver. The liver is a big player.
Okay.
You have HGP means hepatic glucose production. What happens in type 2 diabetes is that you have increased glucagon, which we'll come to, and the body begins to break down glycogen into glucose. So I just want to come off that slide and explain that a little bit.
It's quite a good one.
Right. So we have what is called the dawn phenomena. The dawn phenomena is where in the early hours of the morning, 3, 4, 5 in the morning, your body begins to produce things like cortisol, adrenaline to awaken you and to get you ready for the activities of the day. In men, for example, men have higher testosterone levels in the early hours of the morning, and I always ask our diabetic men about their testosterone levels. Very important that we remember that. But it is part of the awakening process. So what happens to patients is that they go to bed with a blood sugar of 100, 110 maybe, and they get up with a blood sugar of 180. And they say, Doc, well, I had nothing to eat overnight. Part of the reason for your blood sugar being higher is that the dawn phenomena is kicking in.
Right.
HGP, hepatic glucose production, happens overnight. Your blood sugar goes up. But not just that, your blood pressure also very often is highest at 2, 3 in the morning. That's why I want people to remember the best time to take most blood pressure tablets is at night. Because we all know that, and for my year or two working in casualty, people will turn up at 2, 3 in the morning with heart attacks, strokes, etc., because that's when the blood pressure is really peaking. So the third factor, which we call the triumvirate, is the liver. The liver producing too much sugar.
Okay, good.
Yeah.
So that's it. That's the third.
The third factor, the pathogenesis in type 2 diabetes.
And then we come to the disharmonious quartet.
Right. So this is to be called the deadly quartet.
Right.
The terminology here is the disharmonious quartet.
35.
And it's slide 35. By the way, soon you'll be able to ring in on 652-4855. Remember, this is our last live program for the year. So if you have any questions, tonight is a night to ask the questions, or you can WhatsApp your questions on 482-4269, which is our office number, 482-4269. So we're going to slide 35.
When we go to the disharmonious quartet, we're adding another element to these unmet needs in type 2 diabetes.
Absolutely. So we can, right. So again, if we go in an anti-clockwise direction now, we have already talked about the beta cell, the impaired or dysfunctioning beta cell.
In the pancreas. And
in
that's
the pancreas.
That's the organ of the pancreas.
The pancreas.
There above those
That's
green
the head
cells.
and the tail of the pancreas.
Right.
Then you have we just talked about the liver. Hepatic glucose production is increased,
Right.
the dawn phenomena. And then we come around to insulin resistance in the muscle and adipose tissue and fat tissue. And now we have what is called increased lipolysis, increased free fatty acids.
Okay, so what organ of the body is that?
Well, this is being produced from the fat cells.
Right.
So obviously, if you have, we can come off the slide. Free fatty acids lead to impairment of insulin production. It can lead to increased glucose production from the liver, and it produces a toxic environment.
Right.
Now, patients would know they have free fatty acids.
Okay.
It's a kind of, we don't measure free fatty acids routinely, but the way we would know that indirectly sometimes is by if a patient has very high triglycerides, for example.
So they do the blood test.
So if they do the blood test, and very often I see patients coming in with and we've talked about this, their cholesterol levels are not too bad, but their triglycerides are high, their HDL, which is a good cholesterol, is low, and the LDL and VLDL, sometimes the VLDL, which is also bad cholesterol, is also high. So free fatty acids, there's no one drug to target it, but if we deal with hyperglycemia, high blood sugar, if we deal with high cholesterol, then we are indirectly dealing with free fatty acids. And of course, if people apply lifestyle, if they lose a lot of the body fat. I just want to use one example of, another one of my star patients who came in to me on Saturday. About 2 or 3 years ago, he came to me. I think he was about 250 pounds. Over the years, we were struggling to get his blood sugars under control. And he then, as part of his lifestyle, he's a Christian gentleman, he does fasting. And he said he noticed when he was fasting, his blood sugars were obviously slightly better. But then he started exercising and also doing weight training. Over the last 2 visits, his blood sugars came down gradually. On this last visit, I think was on Saturday, his HbA1c was around 6. He was on insulin, 2 or 3 tablets for his diabetes, a cholesterol tablet. He's now come off all his medication. He's come down from 250 to about 190 pounds.
That's excellent. So he's actually reversed diabetes.
He has, so I would say he has gone into remission.
There's a difference between reversing diabetes and remission.
Well, we can have this discussion, because if you say you have reversed a condition, then there's probably no need to go on monitoring it because you no longer have that condition. But it's like people with breast cancer or the fact that I had colon cancer last year. In remission, the cancer has been taken away, but I have to be monitored every year. I need to go back for my tests, and hopefully it will never come back. In that patient, hopefully the diabetes will never come back, but I would be very reticent to say the diabetes is cured. Maybe we could say he has reversed it, but I wouldn't use the word cure.
Okay. No, I didn't use the word cure.
Right.
Okay. Can we move on quickly then to the quintessential quintet on slide 38?
Slide 38, okay. Yeah. So you like these names, don't you?
I love those words.
Quintessential quintet.
Yeah.
And again, we see another, now this is a big one, so we need to spend a little bit of time on this. If we go at the very top, we see something called the decreased incretin effect.
Okay, so incretin is associated with the small intestine from my limited basic understanding of O-level biology.
Right. Now, notice all these 5 factors so far is feeding into the hyperglycemia. So you could see how complex this is becoming.
It is, yeah. It's,
right?
When we get to the ominous octet, I can't believe what happens there.
So if we come off that slide, so what's the incretin effect? When you eat, as you're eating, and the body gets down to from the stomach into the small intestine, there's something called the L cells in the ileum, produces something called an incretin, which is glucagon-like peptide, GLP-1, glucagon-like peptide. This is secreted as you're eating, and it primes the pancreas to start producing insulin. This is why I always tell people, no matter how we try to mimic the body's natural physiology, our God-created organs was created in an ideal way to deal with all these illnesses. Now, type 2 diabetes, there's no indication that necessarily obesity leads to this incretin effect. All we know is that in type 2 diabetes, when you look at the levels of GLP-1, the GLP-1 levels are much lower than people without diabetes. So what happens then is when you eat, if you're not diabetic, your insulin, your beta cells produce a spike of rapid insulin to deal with that meal. I'm at the present time dealing with a patient who came to me from Tobago last weekend, type 1 diabetic. He's only 12 years old, and he's on 4 injections a day. And I've given his parents my WhatsApp number, and they're constantly sending me blood sugars, which is fine. But what they're finding is that his blood sugars are sometimes not too bad before eating, but after eating, despite us giving him insulin, his blood sugars are still spiking up to 200 to 300. Now, we have just changed his insulin around, and it's early days, and we're seeing some better readings. So if you're type 2, what happens is you produce insulin, but rather than a spike, you produce a kind of more gradual release of insulin, a flat curve. And therefore, the blood sugars rise quickly, and maybe after 4 hours, the blood sugars will come back near to normal. So what GLP-1 does is that it allows the beta cells to really produce this spike of insulin.
Okay. I was just wondering about, you know, the effect of having a meal and then suddenly feeling very, very tired, sleepy. I mean, in Spanish countries, they even have a siesta after a meal. So how does that connect with?
Well, I don't think it connects directly with this. What happens when you eat is your blood is diverted from the brain to the stomach.
Right.
To allow digestion, and therefore you have this postprandial after eating drowsiness. And you know,
so if you took a blood sugar reading at that point,
it might be high. It might be high, and that's why one of the blood sugar readings. And by the way, I think now is the time when we can open up the line 6524855, 6524855.
I think we do have a caller on the line.
Yeah.
Yes. Good evening. Can we have your question, please? Good evening. Can we have your question, please? No.
Hello. No.
I think we've lost it.
I think we.
Hello? Yes?
Yes. Can we have your question?
Okay, could you ask the doctor to revisit lifestyle and diet, eating habits for possibly preventing diabetes?
Okay. So we touched on this, and I think at the very start of the program.
Yeah.
And I know you are also big on lifestyle.
Yes.
In terms of prevention of diabetes, there's no doubt if you eat more complex carbohydrates, the gentleman who rang, I'm sure you have access to Googling. Google glycemic index. Low GI foods are better for you. Low GI foods, they are absorbed more slowly, but food portions are very important. The problem in Trinidad is, especially coming up to Christmas, we're going to have lots of carbs. Cut back on the carbs, the white menaces, as we say. Flour.
Sugar.
Why do we call it white? Oh, because it's white.
Yeah, white flour, white sugar, because they're highly processed.
Right.
White rice.
White menaces, that's interesting.
Yeah, they're white menaces.
Yes. So cut back on the white menaces, lots of vegetables and salad, and white meat. So that's synopsis of that. Exercise, and I should be following my own advice here, 30 to 40 minutes of cardio where you raise your heart rate.
Per day or?
I think at least 3 or 4 times a day, 3 or 4 times a week. But it's important that people do resistance training as well, some weights, because what you would find as this patient I told you about, he said to me that when he started doing weights, he found it had a bigger effect on his blood sugars than just the cardio. So that's a lifestyle in a nutshell.
Okay.
Thanks for ringing.
So let's consider, before we go to the break then, the what we call the cetaceous sextet. The cetaceous sextet.
Oh, that sounds very sexy. No, but before we talk about that, can I just say that this whole incretin or incretin effect, GLP-1, there's now a whole new class of drugs called the DPP-4 inhibitors, the dipeptidyl 4 inhibitors, things like Januvia, Galvus, Tradjenta, a whole group of drugs, and also there's a GLP-1 agonist. A lot of patients, you will see a drug called Trulicity advertised on cable. We're still waiting for it in Trinidad. It's a once-a-week injection, something called Victoza. I think when those drugs hit the market here in Trinidad, it will be a big progress or a big step forward in treating type 2 diabetes.
Okay.
Do we have time to cover that next slide?
Well, I think, I'm not sure.
Okay, so we can...
yeah, let's look at it. We haven't got any time slot here.
Yep.
So it's the cetaceous sextet, which is slide 40.
Slide 40. And we like these terms. So we are talking now about, so if we're going in a clockwise direction, starting with the insulin, decreased insulin, you have the incretin effect, lipolysis, decreased glucose uptake, the liver, and now we see the next cell in the pancreas, which is a big player, the alpha cell.
Right.
The alpha cell.
We did the beta cells, and now we're looking at the alpha cells in the pancreas.
Yes. So the alpha. So we can just come off that slide. So one of the things we did not know some years ago was that in addition to hyperinsulinemia in the early stages of diabetes, and then hyperinsulinemia is high insulin, but by the time you diagnose diabetes, insulin levels are falling, but you have hyperglucagon levels. You have high glucagon levels in diabetes.
So the glucagon is coming from the alpha cells.
Alpha cells.
Right.
So this is intriguing. In type 2 diabetes, it's not just the beta cells are malfunctioning, the alpha cells are also malfunctioning and producing too much glucagon.
Okay.
And what does glucagon do? Glucagon releases sugar from the liver. It breaks down glycogen stores. And therefore, that's why if somebody comes in with a HbA1c of 10 or 11%, the new trend in treating is not going slow, stepwise approach, is going high, hard, hitting that patient with triple therapy. Now,
what is triple therapy?
Well, sometimes we would start, if someone comes in with an A1C of 10.5, 11%, we would put them on 3 drugs at the same time. Because what we want to do, we want to stimulate the beta cells, we want to suppress the alpha cells, and we want to deal with insulin resistance at the same time.
And that's all happening in one organ, the pancreas.
Well, the alpha and the beta cells are in the pancreas, but we're trying to deal with the liver, glucose. So that's why metformin, and let me just say, there's 1 or 2 patients sent me something recently from the FDA saying that the FDA is investigating metformin for cancer. I don't know if we have to go for a break.
Yeah, we do have to go for a break.
Okay, so when we come back, there's a little bit of a scare out there. Let me just say, the FDA is making some initial investigations into this, not metformin itself, but there's an ingredient that might be in some forms of metformin, but nothing has been confirmed. And in fact, the people who sent it to me, I sent back to them some research, recent research that shows that metformin might actually be protective against some kinds of cancers. So that's interesting.
Yes. Okay. So when we come back, we continue with Your Health, Your Choice. We're trying to get to the ominous octet. We've looked at 6 of the causes for type 2 diabetes so far. Don't go away. We'll be right back with more information on this integrating approach to healthcare.
Exclusively on ACTN The Voice. This is Messenger TV. Join us as John and Lisa Bevere equip and empower generations of Christians, both young and old, developing uncompromising followers of Christ who transform our world. Starting on Mondays at 8 a.m. with repeats to fit any schedule. Tune in, log in, or click on the word like never before. Stay tuned for a new experience from the Word of God with Messenger TV, exclusively on ACTN The Voice.
Every Sunday at 2 p.m. on ACTN The Voice, we'll be taking you on a journey down memory lane with our Sunday classics. Relive the moments. Bonanza at 2 p.m. Little House on the Prairie at 3 p.m. Gilligan's Island at 4 p.m. Family Matters at 4:30 p.m. Hogan's Heroes at 5 p.m. The Jeffersons at 5:30 p.m. This is Sunday Classics on ACTN The Voice.
ACTN, the voice of Christmas.
Welcome back to our Christmas edition of Your Health, Your Choice, where we educate, you evaluate, and your medical practitioners treat for the diseases that we have been discussing over the last year, 2019. Before we went on our break, we looked at 6 of the causes, and we're moving on now to the 7th. I know that there's something you wanted to share with us before we go into that.
No. We were just talking about the metformin story.
Right.
And I was just confirming that it's very early days, and metformin is still the fundamental first-line treatment, although there's some new guidelines coming, I think, from the European Cardiac Society, saying that if you have a diabetic with cardiovascular disease, there's a new class of drugs that we will discuss now that probably can be used first line in some of these patients. So I'm excited to talk about this next.
So if we could get to slide 44.
Yep, slide 44.
Josh?
Yes. Slide 44.
Septicidal septet.
Right.
Septicidal septet.
So
this is the 7th one.
So if we go in a clockwise direction, we see the incretin effect, we see lipolysis, and now this is the 7th pathogenesis, the underlying problem in type 2 diabetes, the kidneys.
Right.
We see that with the kidneys, you have increased glucose reabsorption. Now, this is when I say completely new concept, this is a revolutionary concept that came about 10 years ago, and it's now really the cutting edge of treating diabetes. So I'll just come off that slide.
So we're going in a...
We're going in a clockwise direction.
Okay.
So the kidneys. Now, we always knew that the kidneys should be excreting sugar when the blood sugars rise, and that's why in the early days, it used to be, there was this myth, or I don't know if it was true, that the old physicians used to go on the ward and taste the urine of patients. I don't know if that's true.
I think in the pre-20th century, that was probably the only way that they could...
to see if the urine was sweet.
Yeah.
And we know if there's sugar in the urine, sometimes people might see ants in the urine. So when this new group of tablets came on the market, which is called the SGLT2 inhibitors, the sodium glucose co-transporter inhibitors, it was a bit confusing because here we were saying we were going to start using a drug that would encourage glucose excretion, encourage the glucose to get rid of sugar. You'd be urinating out more sugar. What became clear was what was happening in diabetes, why we have stopped testing the urine for sugar. We no longer try to diagnose the diabetes by sugar testing.
We do it by blood testing.
By blood testing. Because you could run a high blood sugar of 250, 300 and have absolutely no sugar in the urine. And what was discovered maybe about 10 years ago was that there was a receptor site, the sodium glucose cotransporter 1, and there's a transporter 2, that is acting abnormally, and rather than letting the sugar pass through the tubules, it's being reabsorbed into the bloodstream. So now we have this new class of drugs, and there are 3 now available in Trinidad: Jardiance, Forxiga, Invokana, that is blocking that receptor site. So it's allowing the sugar, as the blood as it is filtered through the kidneys, it's allowing the sugar to be urinated out. Now, again, when people heard about this, the first question was, will it damage my kidneys? Well, actually, the EMPEREG trial, the Credence trial, several late trials now have shown that this class of drugs can give you kidney protection, heart protection, and also one of in the class has been licensed for those with heart failure. So it is changing the face of diabetes treatment. It's almost becoming second line after metformin.
Right. So that's the kidneys then.
Right, but can I just add 2 more things there? Because I know you want to get to the ominous octet.
Yeah, because we didn't get to it last time.
And we will get to it. But the big other thing about this class of drugs is that it can help you lose weight.
Oh, that's good.
It's weight loss, but because you're urinating out more sugar. But one of the side effects is that some people can get urinary tract infections, and we have had a few patients coming back with yeast infections, and sometimes the yeast infections can be quite distressing, and so we have to stop it and put them on something else.
Right. Okay, so we finally move on to the ominous octet on slide 48, please.
And people can still ring in. They still have a few minutes. 652-4855, 652-4855. So at the very bottom of the slide, so let me just summarize. I think we have maybe about 10 more minutes. We started with the islet cells at about 11 o'clock on the screen.
So those are the beta cells.
Beta cells not producing much insulin. Then going in a clockwise direction, we have the decreased or the incretin effect, GLP-1.
Small intestine.
Small intestine. Then we have the fat cells producing too much free fatty acids.
That's all over the body.
Right. Then we just discussed the kidneys.
Right.
That's on about 3 o'clock on your clockwise direction, allowing too much sugar to be reabsorbed. Then you have decreased glucose uptake in the muscle, that's insulin resistance. And now we come to the last one in this beautiful term. Well, is it beautiful? The ominous octet.
It's just an alliteration that sounds nice, but it's horrible.
Right. So the ominous octet. This is the brain. We now know that the brain also has a part to play in dealing with type 2 diabetes. And it's the hypothalamus. So we can just come off that slide and talk about that. So we have the hypothalamus, which is an area of the brain which is the appetite-seeking center. And what we have discovered is that the neurotransmitters in the brain, in the hypothalamus, is malfunctioning. So people don't have... Do we have a question?
No, we just have 10 more minutes.
Oh, we have 10 more minutes, okay. But I just want to remind people, if some people are a bit shy to call in, you can WhatsApp questions on 482-4269 over the next few days at least, because over Christmas I can't promise that we'll be answering questions. So the hypothalamus is where the appetite-seeking centers are. Now, this is where I get into this whole thing about fat shaming, because if we are saying that obesity is a medical problem, which it is, we are then saying that it's not just the patient's fault. Because a lot of patients come in and there's a lot of guilt wrapped up. So we have talked about this ominous octet. What we have not talked about is depression. A lot of our diabetic patients are simply depressed. They're demotivated. They're trying their best. And I really want to say to all the people looking at us this evening, I want to encourage you. We want to come alongside and help you manage your diabetes successfely. You know, I was, proud of one of our patients that was profiled in the Sunday Guardian a few weeks ago for World Diabetes Week. She's 30 years old now and owns her own fashion outlet. She came to us when she was maybe 15 or 16 years old, type 1. Diabetes not well controlled. We worked with her for a number of years. It wasn't easy, but her blood sugars are now well controlled. Still, she has occasional spikes, but she's living successfully with her diabetes, taking 4 injections a day.
Oh, that's tough. That's tough.
It is tough. But now, type 2 diabetics very often don't need insulin, but in some ways, type 2 diabetes can be more difficult to control and can have more problems associated with it. Why do I say that? Because we talked about this whole ominous octet. So when we talk about type 2 diabetes, we're really trying to protect people's eyes, in type 1 as well, but that's why hypertension, so as we're kind of wrapping up, high blood pressure is crucial. A good blood pressure for a diabetic is 140/80 or less. And if you have protein in your urine, we want to get you down to about 130/80. The problem with accurately measuring blood pressure is that when you come into a doctor's office, we no longer, well, most of us don't wear white coats, but patients get anxious for some reason and their blood pressures go up. So if you have, we think you might have high blood pressure, we are now actively encouraging patients to buy blood pressure machines, not just blood sugar machines, and measure it at home and do it twice a day for a week or 2, and then we have a better idea. So we're trying to protect your eyes, we're trying to protect your kidneys, we're trying to protect your heart, your coronary arteries, and of course, we know some sad stories of people who have had significant coronary artery disease and unfortunately had heart attacks, etc. Strokes.
Yeah.
That's a big thing that we're trying to prevent, strokes as well.
Yeah. Okay. So we've got 5 more minutes. Is there anything about diabetes you want to share before we move on to the spiritual?
Right. So as we end and get into Advent, I want to encourage patients that you can manage your diabetes successfully. There is a range of therapies, but lifestyle comes first. I know there are lots of alternative therapies out there. All I would ask you is, if you're going for alternative therapies, do your research and see if the science backs up what the claims are. We can defend thoroughly what we talk about with research data. Make sure that you make wise choices in 2020.
Okay, good. Okay, so it has been, discussed and widely debated and so on. The whole idea of, Christmas being a time for gratitude and joy and celebration. But there are people, as you say, diabetics who are probably quite depressed around this time of the year. And I wanted to share just a few suggestions as to how we can, if you're not really in that mood to celebrate and you're not feeling that grateful, joyful perhaps, what can you do? And I think one of the most important things is that you don't accept any perfect representation of Christmas, especially what the media is projecting. What other people try to make you believe is a good, perfect Christmas. There's no such thing as a perfect Christmas. Become involved in giving, but in a non-monetary way, through charities and worthwhile causes that help people who are less fortunate than yourself. And perhaps one of the most important ones is enjoy the moment and don't become too self-reflective. this is, take action and do active, interesting things to lift your mood. For many of us, this is probably going to be the first Christmas without someone dear to us. And these are just some suggestions that we thought might be helpful.
Right. And we have about 1 more minute?
Yes.
Okay, so we talked about lighting the Advent candles, and we've been doing this at our church. And this Sunday, we'll be lighting the 3rd Advent candle of joy. And we talked about peace last week. And I just want to encourage people to pursue a life of shalom. So this has been the Advent week of peace. And when you might be looking at this next week when it should be joy. But just for this week, you can have peace with God through his son, Jesus Christ. But then we begin to make peace with each other by the way we interact with each other, by the way we speak to each other, extending mercy, tenderness, being slow to anger, quick to listen, etc. So we really want to encourage people to, as we celebrate, I prefer the word Advent, the season of Advent, that we really capture the essence of what this season is all about. It's about the birth of a Savior who came to die for the sins of the world. And that's good news. That's amazing news. It's a story of God's grace to all mankind.
Okay. Well, thank you for joining us on our final edition of Your Health, Your Choice, or live edition of Your Health, Your Choice for 2019. We hope to return in the new year with some new programs, new guests, and continue to educate, allow you to evaluate, and then and together we can prevent and treat your diseases. Have a wonderful Christmas and a very prosperous New Year.